IRB challenges in QI and research. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice-Based Research Network Initiative at the Agency for Healthcare Research and Quality, AHRQ, will introduce today's presenters. We will have a Q&A session with each individual presenter and a final Q&A with all presenters. At the end of the webinar, I will explain how to obtain your CME Certificate of Participation. A copy of the presentation slides will be emailed to all webinar participants, and the recording will be posted to YouTube. Today's participants will be notified once the video is available. If at any point during this webinar you have trouble hearing our presenters, please try hanging up the phone or headset and dialing back into the webinar. Today's presenters have no financial relationships to disclose, and they will not discuss off-label use and/or investigational use of medications in the presentation. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A session, as time allows, your questions will be read out loud and our presenters will respond. I will now turn the presentation over to Ms. Roper.
Thank you, Christina. So today we have an interesting topic, but I want to speak about the auspices for bringing these presenters, Dr. Taylor, Dr. Schreiner, and Dr. Fiks, to you. Last year, in the summer of 2014, at the North American Primary Care Research Group, PBRN conference, the question was raised whether or not AHRQ could support a community of learning about pragmatic trials. And that question was really framed by Paul Mesnier of New York and Rowena Delore and Jonathan Tobin. And they have served as leadership on an ongoing pragmatic trials working group, which is mentioned, they meet about every other month, and it's mentioned in the PBRN biweekly when they have new meetings. We anticipate their next meeting will be in August. Through that discussion, there was a unanimous request to have presenters, and particularly Dr. Taylor and pragmatic folks up in Philadelphia, Dr. Fiks and Dr. Schreiner, with respect to some of the challenges for IRB review and quality improvement and research, and sometimes the how to differentiate the two. We have a robust group of people participating as potential folks querying. So we have 263, which is compared to those that are registered, we've had a much higher batting average of folks who are actually coming, and we're glad to have you. And so, as Christina said, pose your questions. I'll try to map them to the speaker. As you well know, this is a somewhat evolving and sometimes contentious area. So we look forward to discussion and recognition of context, of personal experiences, and perhaps direction to a breadth of literature that will be available. So I will give an overview of our three presenters. Our first presenter, Dr. Holly Taylor. She is currently at Johns Hopkins and has had a distinguished career. She began at Stanford and went on to the University of Michigan for her PhD in health policy and bioethics, and then came further east for Johns Hopkins. But fear not, we were chatting earlier, and her she's quite fond of the West Coast as well. And I'll just go ahead and introduce the presenters. Our second presenters is really a team. Mark Schreiner, who's from St. Louis University Medical School, where he received his MD, and is a pediatrician, and he currently works at the Children's Hospital of Philadelphia. His anesthesia residency at the hospital at the University of Pennsylvania, and is doing ongoing research at CHOP. Dr. Schreiner has been a member of the anesthesiology and critical care medicine at Children's Hospital of Philadelphia since 1984. So he will give perspective and experience for children's health and some of the challenges for consent there and IRB issues. And he will be joined by Dr. Alex Fiks, who is a well-known member of the PBRN community. Dr. Fiks is Assistant Professor of Pediatrics at the Perelman School of Medicine at University of Pennsylvania. He's also the Associate Medical Director for the Pediatric Research Consortium, PERC, and has several distinguished achievements. And he is quite progressive in his guidance of the use of health IT and the evaluation thereof, and including clinical decision support, telephony, and social medicine. So we look forward to their presentations today, and I'll just echo what Christina said earlier, that we will be happy to distribute a PDF of the presentation, and once the YouTube link is available in a few weeks, we will let you know that as well. And for those of you who are medical doctors, you can use this experience to apply for some continuing education credits. So with that, I will turn it over to Dr. Taylor, who will speak about the simple interventions to improve informed consent. Dr. Taylor?
Thank you. Let me just hit the right button here to get it to slideshow. So, hi, thank you very much to the PBRN for letting me have the opportunity to share some work that I have contributed to. I will say that I will not be talking about quality assurance and or the difference between quality assurance and research. I'm going to talk about simple interventions to improve informed consent, which I would argue could certainly be applied to either quality improvement or what we think of as more traditional human subject research. So before I start, I just want to acknowledge that I will be speaking about a project that my colleague Nancy Cass was the PI on. I was a co-investigator, and this is the source or the article that I'm going to be speaking from, where you can get all the details of the project that I'm going to try to summarize and cut to the chase through relatively quickly. I also just want to acknowledge my other co-authors. So let me give you a little background. Some of this, it will not be news to any of you. We know from all sorts of interesting empirical research that's been done in the past that participants, study subjects, have poor understanding of their research experience. Some report when asked that they were unaware of enrollment, and we also know that subjects have a particularly challenging time understanding benefits, potential risks, and concepts that are fairly unique to research, like randomization. The other thing we know, let's see, I'm hitting the wrong button here to make it go to the next one. Aha. The other thing we know, again, not news to any of you, is that consent forms are long and complex, and we've known for 25 years that forms are routinely written at grade levels that are much higher than the average education level of someone that we would encounter in the clinic, and we haven't made much progress. That said, given that consent forms themselves haven't changed much, many have tried to identify methods to improve subject understanding. And there's a sort of mixed evidence across the board in the research that's been conducted to date, but two things stand out. One, that shorter forms seem to encourage better understanding, as does dialogue with a study team member, and that's anyone from the PI to the research nurse, anyone who is a member of the study team and knows something about the research. The challenge that we took on with this project was that if you look at the literature, and there's one very good review of interventions to inform consent, and another that's not quite as good in the literature. If you look at those reports, they're systematic reviews the vast majority of work to date had been done in simulated settings. And again, we all know that asking someone hypothetically about their enrollment and asking them to read a consent form for a project that they would never actually ever be enrolled in has some challenges in knowing whether or not the intervention that you've developed might have some effect. I would argue that if anything, because you really don't have the disease under investigation and you really aren't in the position of having a health crisis that may mean you need to enroll in a clinical research protocol, reading a form and knowing that you're going to be tested on it may bring you to a conclusion that either the baseline understanding is going to be quite high because you have nothing else on your mind, or the intervention that you've developed might improve something, or it might have improved it if you had a whole lot of other things on your mind, but we don't know. So that's a long way of saying our goal was to develop and test simple, feasible, inexpensive interventions in ongoing trials. The challenge with that, of course, is that we had to find a lot of collaborators, which I'll get to in a minute. But what I want to do first is tell you a little about the intervention. So the intervention that we developed had two parts. The first was a bulleted fact sheet about the study. This was to be used in addition to the consent form. A quick tangent to say that it's a challenge to get IRB approval for research on research, especially in the consent process. So part of the reason why the fact sheet was used along with the consent form was that the IRB wanted us to make sure that the consent form was used as well. The second part of the intervention was a structured conversation. We refer to it as voice, and each research participant is asked to answer a number of questions, and the research coordinator was trained by us and then corrected anything that the subject identified in their response to the questions that was incorrect. So let me just show you I'll talk a little about this process. What we did was we identified potential collaborators. They then shared with us the consent form that had been reviewed and approved by the IRB. We then took those forms and in collaboration with them, usually the PI and a study coordinator, identified the key pieces of information that they thought every subject needed to know. Now, of course, all of that is in the consent form, but one of the critiques about the consent form is that sometimes relatively important information can get buried into the last pages. So we wanted to create a short, brief, concise set of points that were in a large font, lots of white space. We adopted and used all the things we know in the adult literacy literature about what enhances understanding, short sentences, small words, etc. So I just show you here to note that it looked a little different. In general, the form was 1 to 2 pages that complemented the consent form. So as you'll see on the right here, the first block takes up half the page. The next page would be the continuation of that block, and in some cases it was a little longer, but on average about 2 pages long. The structured conversation was just a set of structured questions, and this is not something that we came up with. It's something that many others had used in the past, and we sort of pick and chose what we thought were the best types of questions to ask subjects. The questions were here as follows, and we either used the first 5 or 6 or the full set. You'll see what I mean by that in a second. So these are the questions we ask. If you're going to tell a friend what the study was about, what would you tell them? What are the main things that are going to happen? What are the risks or the bad things that might happen if you join? What are the benefits or good things? What will happen if you decide not to be in the study? What if you decide to join and change your mind later? And then, depending on the trial, the research coordinator will also ask whether everyone in the study gets the same thing, and or tell me in your own words how they're going to decide whether you get the new thing or the usual care, or depending on the trial, how it was designed. We then assessed understanding, and I'm going to show you in a minute how we actually implemented our study, but we again took basically the best we found in all the instruments that other people had developed and developed an instrument that we thought then best assessed understanding. We had both open and closed-ended questions, in part for methodologic reasons. The items were meant to be generic to any study in general, but we also crafted some specific questions, usually based on the key points that the investigator and study team had said were the most important things, and then we assessed a bit of their attitudes and opinions about the process and got some basic demographic information. We also, to get a baseline sense of education level, used what's referred to as the rapid estimate of adult literacy in medicine. It's basically 3 lists of words that you ask someone. It's very quick. It hadn't been done over the phone before we used it, but we found it to be highly reliable over the phone. So now I'm going to sort of put all these pieces together and share with you what actually happened in real time. So because we didn't want the use of the fact sheet or the structured conversation to contaminate, using the technical term, the engagement between the patient and the subject, what we did was we phased the intervention in. So we couldn't do, or this was a feasibility study. We didn't do a randomized study. We thought about doing one and actually sought funding for doing one, but were unsuccessful in doing that. So with knowing the limitations of doing a phased-in study, what we would do, for example, is collaborate with an investigator, ask them for 6 patients for their study coordinator to use a standard form. Then they would refer them to us on the phone, where we would do realm and the understanding evaluation. The next 6 patients that they enrolled, we asked the research coordinator to review the fact sheet with them, then do the standard form, have them call us. We did the realm and the queue. The final phase, next 6 patients, fact sheet, standard form, introduce the structured conversation. Then they referred us to do the realm and the queue. We had 8 collaborating studies. 3 of the studies we were collaborating with failed to enroll a minimum number of people. So we had 11 studies that were interested, but 3 sort of fell off as their projects didn't develop the way that they anticipated. Just to give you an idea, we purposefully went for a very heterogeneous group of collaborators because we wanted to really test the generic question of whether or not either of these interventions, the single fact sheet or the fact sheet and the feedback question set, would be effective. So we had emphysema progression, an eligibility trial comparing oral health in folks with autoimmune disease, a randomized weight loss trial comparing meat and mushroom diets, looking at a new test for glaucoma, and then a study creating a GWAS study registry for a particular condition. Also a phase 1 sponsored trial for a new HIV combination or combination with a standard TB drug, and then a randomized phase 2 study of scleroderma patients. We enrolled 144 subjects. One of those asked to have their data removed, so the rest of the data is just about 100 and, actually, the rest of the data is about the 144. The one who asked to have his data removed was the 145. The mean age of the subjects that we were able to enroll were 51.5 years, about 2/3 women, half white, another large set were African American. As I said, we had some, challenges in terms of design. So what we were able to note is that as measured by responses to the open-ended questions of our assessment tool. As I said before, it had both closed and open-ended. Subjects who received the fact sheet and the structured conversation did better on understanding of key elements than those who did not. As I said, this was a feasibility study. Our hope was to then test it in a more robust randomized clinical trial. That said, these two interventions showed that there was some improvement understanding. We just can't really yet say, right? The really important question that I can't necessarily answer is, does this mean, is it a big enough difference, right? This is a statistically significant difference. A clinician might say to me, well, what does that mean for the health of the patient? I can't really say that, oh my gosh, this was such a huge difference, everybody should do it tomorrow. I still think everybody should do it tomorrow, but we don't have a large enough sample to show that large difference. I wanted to end by highlighting just a couple of what I'll call lessons learned. So to step back to the beginning a bit, our original plan was to collaborate with investigators and modify their entire consent form as a component of the intervention. We found that to be neither feasible nor practical. On the feasibility side, you can imagine that when folks are doing multi-center trials, you know, allowing us to basically start from scratch and develop a new form just was not going to be feasible. The collaborating institutions would be reluctant, and or in some cases investigators thought the corporate sponsors would not be willing to let us do that. So we stepped back from that and developed the fact sheet. The other important thing that I'll say, and something I think is just a general truth about consent, is that we tried this out with one form, and so it was myself, Dr. Cass, and then a colleague of ours, Joe Ali, who's trained as a lawyer. It took us, we didn't count the hours, but it took us a really long time to revise forms, and I think we're all pretty well trained and understand how one might pursue getting informed consent in a thoughtful and responsible way. So we knew right away that asking investigators to step back and redo their forms, we would have had to create a book-length treatise on this is how you need to do it. So we also wanted something to be feasible. We couldn't go and revise everybody's consent forms, and we knew that wasn't going to be feasible. The second is that we learned early on that it was really important to train the research coordinators of the collaborating studies. So what I mean by that is that those questions that we asked the research coordinators and the study teams to think in advance what the answers to those questions ought to be. And in some cases, research coordinators didn't quite understand the role of those structured questions. They would come back to us and say, well, they got it wrong, but I didn't know if I should correct them. Where, of course, you know, our goal was to have them correct the subject with the idea of increasing their understanding. So we learned early on to be much more intentional about that training. And I'll say that the last thing that we appreciated was that both interventions were very highly regarded by study staff, that they really liked the fact that they could use simple things like a fact sheet in addition to the consent form and these questions, because it gave them a sense that their subjects actually understood the information that they conveyed. So I will stop there. I hope that that was clear, and I'm happy to take a couple of questions. My understanding is we're going to take a couple of questions now, if there are any, and then transition to the rest of the presentations, and then I will also be available at the end if no one has questions now.
Great. Dr. Taylor, well, a couple of people do have questions. And you, with respect to the different approaches, you acknowledge that staff like both versions of the intervention, and the development of the fact sheet was pursued, and you can correct me if I misstate, due to it would be problematic for you to revise the consent forms across the different studies and or locations. Did you, by chance, have an opportunity in this proof of concept study to assess whether the different types of consent were better or less well received by the patients?
Really good question. So we asked them, as I said in that assessment, we asked them about their opinions and how they use the consent form. So some people would say things like, you know, I took the consent form home and I used it as a way to help inform my spouse, brother, sister, whoever it was. But what we didn't do, our goal was to test the effect of our interventions, and we intentionally didn't change the actual form because that would have created complications. And so we didn't ask individuals whether they liked the original consent form or not. You know, we certainly could have done that, but again, our goal was to assess our interventions, not the forms themselves. All of our fact sheet interventions were highly similar across sites. So we used the same language, of course, with different facts depending on the case. We used the same sort of spacing, the same size font. So all of our fact sheets were, you know, as similar as possible, but we intentionally didn't change the form, and we didn't ask them about the form itself.
Great. So your fact sheet as a device has prompted several questions, very appealing. In the actual conduct of the study and your use of the fact sheet, could you articulate kind of the order of the presentation for the consenting process?
Sure, absolutely. And so it's a really good question, and I'll answer it in the following way. One of our goals under the heading of wanting to be sort of feasible and easily adoptable, we left it to investigators to decide whether to use the fact sheet first and then review the consent form, or use the consent form and then use the fact sheet afterwards. And we did that again because we wanted to be we wanted to be assessing what was close to practice as possible. I'll say that the vast majority of folks used the form, our fact sheet first, as sort of a primer, you know, of sort of like, here are the important points that I'm going to cover. So keep these in mind as I go through. And patients were given the option of taking either or both our fact sheet and the consent form along with them. So what would happen is they would, you know, introduce the study through the fact sheet, then review the consent form, and if they were not in the third arm of the study, they would send the patient to a phone to call us, and we would assess their understanding. Or if they were in phase 3, they would review the fact sheet, review the consent form, do the open-ended questions, provide corrective feedback, and then direct them to us to do the assessment of their understanding. The form itself, as I said, it was, you know, generally used before the consent form.
Great. So we have a few minutes before we can hear from Dr. Schreiner and Dr. Fiks. So I have a couple other questions for you, Dr. Taylor. Since you're we'll take advantage of your expertise in informed consent. And listening to grant applications during the review process, on occasion when the applicants are choosing to include a vulnerable population, they sometimes do not address that fact well with the regulations and particular protection of human subjects plans. Do you have any recommendations or possible resources or references that might facilitate?
Sure. Yeah, so as you rightfully note, when we use the term vulnerable, if we think of that in a merely, and I don't mean that pejoratively, regulatory way, that immediately takes us to, is the subject a child, a prisoner, a fetus or neonate or pregnant woman, But we all know that there are a whole lot of ways that individuals might be vulnerable. I've seen people argue as far as to say that anyone is vulnerable. People who are sick are more vulnerable than others, but we all have vulnerable characteristics. That said, that's not a very, I don't think that's necessarily helpful, because then it doesn't really get you any further. So when I teach the issues around obtaining informed consent from subjects, a framework that I often refer folks to is one that was written by Ken Kipnis now back in the early 2000s for the National Bioethics Advisory Commission. I don't think it's the, the only source of information, but it certainly gets folks thinking, and I'm just sort of turning to the page in the book. He articulates a couple of different ways that we can think of folks in terms of vulnerability. There is cognitive or communicative vulnerability. So again, if we think about obtaining consent from a patient with dementia, there is no, CFR part for adults with memory problems, but we ought to perhaps think about folks with cognitive impairment as being vulnerable in a particular way, and that may then guide our choices about who, when, where, how we obtain informed consent. He also lists institutional vulnerability. Again, the first thing we might think is someone in a prison setting, but you can imagine other types of settings that may similarly put people in institutionally vulnerable positions. Deferential vulnerability, which means, sometimes that can mean that the person who is obtaining consent has more power by nature of their professional role. Medical vulnerability, which is sort of easy for us to understand. Economic vulnerability, again, thinking about what the SES level of the subjects that you are approaching, would offering money be an undue inducement, for example. Social vulnerability, so folks who just may not have the same experience that someone who often comes to an urban, medical center has. I think of work that I've done overseas with folks where research isn't even a common consideration for them in their daily lives. So you have to sort of address that first before you can get to the nitty-gritty of consent to a particular project. And what he then concludes by is that it's our responsibility, meaning investigators, IRBs, reviewers, to consider and align those vulnerabilities. We all know that someone could have all of those vulnerabilities at once, or that they could have one or two. So our role is to think carefully about how the population may be vulnerable and then tailor the process of informed consent to really the least common denominator, right? That if you anticipate half of your subject population is illiterate, which could happen across the street from me here in East Baltimore at Johns Hopkins, I should be really careful about the materials I use during the informed consent process. I would never say to the person, here's the form, why don't you read it, and I'll be back in 30 minutes, right? That's just disrespectful, much less attending to a vulnerability that they may have, meaning they're not actually literate and would be too embarrassed to tell you that they can't read. So I'll finish. I'll stop there. I could go on and on.
That was great, Dr. Taylor. And so we appreciate that you're going to stay on the webinar with us, and we look forward to chatting with you after we hear from Dr. Schreiner and Fiks.
Great.
Okay, we're up with you. Okay, I'm Mark Schreiner, and I'm going to just start off with some overview of the quality improvement versus research. And just as a statement of the problem is that many people feel that quality improvement efforts are being hijacked by overregulation with requirements for IRB review. And then as an IRB chair, I would say that some clinicians are trying to force the IRB to regulate them when it's not necessary because they believe that they need oversight. So it happens in both directions. Quality improvement is integral to the practice in a clinic, in a doctor's office, in a hospital, and it's a mandatory activity. And in contrast, research is optional. It is about generating new knowledge for future patients. It's not about the care of the patients that are here today. However, there can be some overlap between those two. And this is how we within our IRB think about what's going on. There's a large sphere that's human subjects research, some of which is exempt, some of which can be reviewed using expedited procedures. But there are other things that we're asked to look at that's not research. And then there are things that are research, but they're not human subjects research. But we're only concerned with everything that's within that yellow sphere. There is, however, a small group of activities that are both quality improvement and research. So this is the way the IRB would think about anything that was submitted and how to judge it. And the first question we ask is this research? And if it's not research, then the IRB is done. There's no additional activities that have to take place. If it's research, we then ask, is it human subjects research? And if it's not, then the IRB is done, and the individuals who are submitting the proposal are free to go do what they want to do. Only when it's human subjects research does it then go to the IRB. So research and defining what is research is the tricky thing. In the regulations, it means a systematic investigation that could include research development, testing, and evaluation, and it has to be designed to develop or contribute to generalizable knowledge. It's a set of behaviors or processes. It's not an outcome. So if the outcome will be generalizable knowledge, but that's derived from a process other than research, then it's not research. So there are many systematic activities that are not research, quality improvement being one of them. There are administrative activities that are not research. So generalizable knowledge is an outcome, and it can come from many different areas. In the Belmont report, they described research as being described usually in a formal protocol that sets forth an objective, and that objective should be a research objective with a set of procedures designed to reach that objective. Whereas quality improvement is usually an iterative process, and this is the PDSA or PDSC cycle, where there's planning, doing, studying, acting, noticing what the changes had or not had as a result of the change. Was there an improvement? Given that healthcare organizations are obligated to improve and to evaluate their processes, it would be silly to implement change and not be allowed to assess the impact of those changes. So I'm only going to look at a table which sort of puts side by side the differences between human subjects research and quality improvement. The most important is the purpose of research is to develop or contribute to generalizable knowledge, where quality improvement activities are designed to implement knowledge and assess the impact of a process or program. And often the design for human subjects research should be a rigid protocol, where quality improvement frequently is adaptive and uses an iterative design. The benefits from research are not generally the current subjects. They're intended to benefit future individuals, whereas QI is directly intended to benefit people being cared for in the clinic, in that practice or that system as soon as possible. So with that said, there are QI activities that are research. If it introduces an untested clinical intervention for improving the quality of care, but also collecting information about the safety and efficacy to establish the scientific evidence, then it's could be both QI and research. So here's another way of looking at it. There's all kinds of administrative activities, clinical management, innovation, there's quality improvement, and then there's research, and there's a little intersection between the two. So from the IRB's perspective, what are the things that are flags? If the intent is to develop new knowledge or validate new treatments, it's probably research. If you're using a research methodology, randomization, blinding, things like that, it's probably going to turn out to be research. If it's a fixed protocol with a rigid goal, it might or might not be research, but that's just another factor to look at. If the risks are greater than minimal, then it's almost undoubtedly research. Quality improvement activities should be no greater than minimal risk. And lastly, there might be some requirements from the funding source which might require IRB review, even if the IRB would otherwise not consider it to be research. So if we get something that comes in, we say, is this research? And we say, is this an activity, an investigation? Is it a systematic investigation? And then is it designed to develop or contribute to generalizable knowledge? That doesn't mean that generalizable knowledge won't result, only that it's designed primarily to contribute to generalizable knowledge. So this is kind of the flow that we would follow within the office. So just a brief reminder that a human subject is a living individual that the investigator interacts with through an intervention or an interaction, either with the person or their identifiable data. So to say if somebody's a human subject, is it a living person? Is the data obtained through interaction or intervention? Is the data private information compared to publicly available information? And then can the identities be readily ascertained? And if the answer to all of those is yes, then it's human subjects research. So I'm going to turn it over to Alex, and we're going to have some case studies and hopefully some questions and conversation. Okay, we'll get back.
All right. Hi, everyone. I'm Alex Fiks. So Mark and I wanted to set up this part of the talk to really kind of engage in some of the more detailed thinking about particular cases, which can illustrate and clarify our thinking about some of the points that have been mentioned already, and then we'll look forward to getting additional questions from the audience. So the first case involves a parent satisfaction survey with a fast-track clinic. And so the purpose of the survey is to determine the parent satisfaction with the staff, healthcare provider, and the overall care at this particular clinic. So that's the goal. It's really focused on that one clinic. Providers will note the child's diagnosis, the time spent for the visit, and comment on whether or not the child met a fast-track clinic criteria. The intent is to improve the triage of patients and to improve parent satisfaction with care. In a project like this, it's envisioned that there'll be multiple cycles of improvement with learning at each stage that then informs subsequent changes. And so I'll pass it over to Mark and just say, from an IRB perspective, how would you think about this one?
So many people think that if you're interacting with people, that makes it research. But we would look at it first, is this research? And it would seem that the intent is not to produce generalizable knowledge, it's to improve the care for patients in the clinic today, tomorrow. So the methods, questionnaires, surveys, focus groups, talking to parents, those methods, while they involve an interaction, the goal is not to research, it's to improve care. So we would consider this a classic quality improvement activity, and if it's not research, then we don't even get to the question of, is that a human subject?
So here we bring up this research question, and we both felt it fell short on is the primary goal generalizable knowledge, or is the primary goal to improve practice at this particular site? And in this case, we felt the primary goal is to improve practice at this particular site, so it doesn't quite meet the criteria for being research at all.
So it might have been an investigation, namely trying to learn something, and it might be systematic. Many things are systematic, but it's not designed to develop or contribute to generalizable knowledge or to knowledge.
So the second case evaluates the impact of streamlined documentation tools. So a lot of different sites around the country, a lot of different practice-based research networks are focused on this. And in here we're conducting focus groups with clinicians working in outpatient settings to optimize the electronic health record. The plan is to develop and implement problem lists and other tools to improve the experience of working with the electronic health record, and then to conduct a second round of focus groups to determine the impact of tools on satisfaction with the EHR. So, one question that came up as we were talking earlier is who's the subject of this investigation? Is it the children who are cared for by the clinicians using this EHR? Is it the clinicians, or is the process itself?
So the question we would ask is about a human subject is someone about whom the investigator obtains information. And here, the about whom is the electronic health record, perhaps rather than individuals. So, but even so, there's been an enormous increase in the amount of electronic health records being implemented as a result of the Affordable Care Act. There's been something like $29 billion spent by the federal government to aid in this development. And healthcare systems need to have the ability to develop and implement those problems without being burdened by the regulatory oversight of research. So focus groups can be human subjects research, or they can be used for other purposes. In this situation, I would say this is a classic quality improvement or administrative improvement activity that is not primarily designed to produce knowledge, but rather it's designed to improve the system in which healthcare is being delivered.
And would that matter at all if these researchers, this team was specifically collecting identifiable information about the people who were participating in the focus group?
Well, that wouldn't change things, but it does point out that many people think that quality improvement initiatives need some sort of oversight structure so that they appropriately deal with privacy and confidentiality and data storage and protecting individuals from recriminations, job discrimination, things like that. So just because it does not require IRB review and approval doesn't mean that institutions are alleviated from the requirement to provide oversight for that activity. But they're just, the IRB system is not the correct system to do that.
And here again, we ask the question, is this research, and it falls short on the primary focus not being generalizable knowledge, even though one could potentially describe this as an investigation. So the third case is exploring the transition of medical care to adult providers and conducting a gap analysis. So the objective is to identify best practices, constraints, and gaps in service related to the transition of children to adult primary care. There's surveys of the providers, and the goal is this understanding of current gaps in care and also best practices that will then be used to design future initiatives to improve the transition from pediatric to adult care. So two questions. First, is this research? And second, if it is research, is it human subjects research?
Well, the intent is a lot, in fact, it's everything. And if the intent is to improve the services that are delivered within the practice or the healthcare system, then this is quality improvement activity. If it was designed to be a research activity, and it could be with some alteration, then the about whom they're trying to obtain information is the system, the practices, the delivery. So that would fail to qualify as human subjects research. If they were asking individuals, if they developed a research question related to this gap, and they were asking the individuals for their personal opinions about things and their years of experience and their training, then it could be transformed into human subjects research. But as structured, this would be judged to be quality improvement and not research. Each of these cases, by the way, are actual cases that have come to the IRB and which we've looked at. We've sort of simplified them, but these were actual submissions where we were asked to make a determination.
So here are the two rounds of questions. The first, again, is this research? And then the second, if it was determined to be research, is it human subjects research? So the next one, this one involves improving the process of tacrolimus, medication drug monitoring. So the objectives are to decrease the rate of clotted or insufficient samples for outpatient blood tests. The intent is to improve family satisfaction by decreasing the need to repeat lab tests. And the plan is to look at existing and prospective records to examine the timing of procedures and the method of blood draw. So here there's a big focus, as you know, distinguished a little bit from some of the prior cases. I'm doing chart reviews and understanding what's happening with these records, and these records are of individual patients. So does that affect how we think about this?
So the problem here is that one of the units in the hospital was having a lot of clotted samples, and the children were having to have a second blood draw, and families were quite upset about that. So this was addressing a problem that was occurring in one specific unit, actually, and the intent is to reduce the number of needs for repeat blood draws. So this is a classic quality improvement activity to try to improve the care for patients being seen right now, not future patients sometime remotely or for sharing this information. This is about improving the system of the delivery of care.
All right. So again, here we would say this particular case would be an activity that's not research in the gray box, and that would fall under QI.
Yes, but not within the yellow circle.
So case 5. So this one, both of us agree, is a little bit more tricky and something that a lot of practice-based researchers are increasingly involved in. So here, the question is about participation in a registry. Patient data comes from multiple sites and it's sent to a data coordinating center. It's used to produce both site and patient-specific UI reports. De-identified or limited data sets can then be requested from the data coordinating center for research purposes. So although the initial intent is to house the data for QI, it can also be used for research, and the data coordinating center fully acknowledges that the data might be used for research in the future. And the question is, does the creation of this registry require IRB review, or might IRB review be needed at a subsequent stage, and how does PBRN researcher think through these issues?
So we had a related question to this just today. The neonatologists wanted to know whether their clinical database that they use to manage care and to assess outcomes, whether they needed IRB approval for that. And registries that are used to manage patients' care and to benchmark against other institutions, those activities are not research. What happens, however, is we're all aware now that collecting large amounts of data, big data sets, are useful to for asking research questions. And so as long as the data that's collected is limited to what's necessary for the quality improvement activity and for helping to manage the patients, then the individuals who are supplying that data are data providers, and they're not engaged in human subjects research. The Office of Human Research Protection has a guidance document on engagement of institutions in human subjects research, and they have a set of activities that are listed as not being engaged, and providing data to an investigator or to somewhere else is not being engaged. What gets a little tricky is that a lot of centers, they'll consider this to be research. And so if you're the data coordinating center, we've advised individuals to get IRB approval, even though they're receiving de-identified data sets or limited data sets, because some institutions won't participate unless there's oversight. So I think there's a lot of disagreement between systems, different institutions on how they treat this. My opinion is that if it's the same data that's used for quality improvement activities or for clinical care management activities that will be used in the future for research, and sharing that data as part of research will involve data that can't be identified again, then this is a quality improvement activity. There are many organizations that mandate certain types of participation in registry. A lot of the cardiac surgical groups have to work with the American Thoracic Surgeon Society and supply data and get benchmarked. And we see the same thing in interventional cardiology. So many of these activities are viewed as mandatory if they're going to be accredited and receive to be allowed to participate. I think the same thing happens with kidney transplantation, liver transplantation, a number of these other activities. And it is obvious that that data can be used for research in the future, but that's not the primary reason why the activity was organized. On the other hand, if in addition to the data that one needs to do the quality improvement and to do the clinical care activities, or collecting additional data purely for research, then that activity is getting transformed, so at least a portion of it is intended to be used only for research, and that might result in a different decision.
All right. So this is another one that came through. So this was a trial to improve outpatient asthma care. This was actually a study that was funded by the Agency for Healthcare Research and Quality. Practices were cluster randomized about 10 years ago. Practices were cluster randomized to a multi-part intervention, including education, electronic health record decision support, and receipt of spirometers. The objective was to determine if the intervention improved patients' asthma outcomes, and the data from all physicians' patients with asthma meeting age criteria was included in a data set that was then analyzed. And so this has a little bit of a different flavor in terms of being a systematic investigation. What's the IRB perspective?
So the intent here seems to be to develop new knowledge rather than to implement existing knowledge. And that immediately puts it into the research realm. And in addition, although the objective is to determine if this improves patients' asthma outcome, it's really to develop generalizable knowledge to make a recommendation about future patients and improving other people's outcomes through ability to apply what's learned from this to other situations. So on many levels, including the methodology, that we would find this to be a research activity. And the subjects, the primary subjects, are actually the physicians for whom the intervention is aimed, and then the patients are secondary subjects, and there would be complicated issues about consent, who needed to consent, could we waive consent, but that's sort of beyond what the goal is for this session.
Then again, this one, you know, it meets the criteria for generalizable knowledge in its research, and then, you know, would ultimately meet the criteria for being human subjects research as well, involving private information, systematic investigation of living individuals whose identities could potentially be ascertained. So, final example, so a Part 4 maintenance of certification program to improve vaccination rates. So an iterative process is implemented with an objective of preventing missed opportunities for vaccination. It involves some training and some feedback. The plan is to implement document the intervention and measure change with each PDSA cycle. There's a survey that's conducted to learn providers' impressions of the program, and there's right from the outset a plan to publish to help inform other MOC projects and guide their implementation.
So, as with other systematic administrative, quality improvement, research, all of those may be systematic activities. And they may all wind up with lessons that are learned that are worth sharing. But only when the intent or the design of the process is to produce knowledge, rather than, in this case, which I would say it's designed to improve the vaccination rate, rather than designed primarily to produce knowledge, would we consider it to be research? So in this situation, I would say this is a quality improvement activity. The mere desire or intent to publish the lessons learned from that quality improvement activity does not make this research. So, but there are many people who are finding pushback from journals who want IRB determinations. We write a letter that says, we'll issue a letter before the project begins saying this is not a research activity. So for those who are interested, this is a relatively short article that summarizes the differences between quality improvement and research, and it's based on a much longer report in the Hastings Center Journal.
So acknowledgments, we want to especially acknowledge the Agency for Healthcare Research and Quality, funding of the P30 Center, research centers in primary care, practice-based research and learning, and additional support from the Health Research and Services Administration of the U.S. Department of Health and Human Services. So I think at that point we're open to questions.
Well, thank you both very much. There are several questions. Just to reiterate, the PowerPoint will be distributed after this presentation, and we are going to add the additional citation that Dr. Taylor had with respect to the description of vulnerable populations. So just to announce that. Now, several questions have been posed in hopes of asking the three-year doctors to give their assessment of something, whether or not something requires IRB approval. And the purpose of this presentation was not to have that type of response or burden placed upon our three presenters, though we may, they've given us some excellent examples of their case studies, and they've distilled so succinctly the findings for that particular group. But I'm sure Dr. Schreiner and Dr. Fiks would say that at times a lot more discussion and deliberation went into those considerations and those findings. So what I'm going to do is talk about or present to the three presenters some of the thematic questions and ask them to address them. So several times in the questions posed, I think they're phrasing it in this way: if I go to publish, does that require a different level of burden with respect to protection of human subjects and IRB review? And Dr. Schreiner spoke about the IRB with respect to issuing a letter early on. I will turn it over to Dr. Schreiner and Alex, and then ask Dr. Taylor. One thing to keep in mind as well in the publication, if you are using a randomized clinical trial with funding from HHS and you have not registered your clinical trial, that can limit your ability to have published results. Would you care to comment about whether or not publication should be a factor?
I don't think publication is a factor at all. I think some journals think it's a factor. If you think there might be a question, if the journals that you publish in raise this issue, then you should get a determination from your IRB before you begin that what you're doing is not human subjects research. Because the IRB can only review and approve things that have not yet taken place. So if you do a QI project and you say, hey, this is really interesting, we want to publish it, at that point in time, it's too late to ask the IRB for an opinion because it's already happened. Although I think we would be happy to say that this activity was not research. But ideally, if you think that's an issue, you should get that ahead of time. Publication and research are not equivalent. We would hope that many successful QI interventions and activities would produce lessons that are worth sharing with others.
I think Holly maybe. Holly, did you want to add to that?
Yes, I assume I can be heard. I just wanted to absolutely endorse the idea that publication ought not to be a consideration in evaluating whether or not something ought to go to the IRB. One important implication for that is that the IRB then has a lot more work than they would otherwise. But I also want to endorse the idea that if you ever have a question before you embark on your project, go and talk to your IRB. They love to talk to people about their work, and it's always better to get an answer before you start than to feel frustrated later that you're arguing with a journal. If you have in hand a piece of paper from the IRB that says, thanks for asking, what you're doing is not research, you can then forward that with your request for publication. It shouldn't be a default. I'm going to publish, therefore I must send to the IRB.
Great. Thank you very much. And Dr. Schreiner brought up, he was speaking about clinicians and one of the particular case studies as being human subjects, and I think the patients he referred to as secondary human subjects. One common error in grant applications that I've seen is when it comes to the plan for protection of human subjects in the target enrollment table, for each intervention, you should really address the protection of human subjects for each intervention and subject group and have the appropriate target enrollment table. And at times people merge them all together, and oftentimes they overlook the clinician as being human subject, especially medical students. So it's a common challenge that can be addressed after award, but can reduce your score, even though protection of human subjects and IRB approval is a just-in-time requirement. Since you have been listening so well to one another, Dr. Taylor, is there a particular question you'd like to pose to Mark and Alex? A reflection that you would like to make?
You know, I found it really helpful and I assume it was very helpful for the larger group too, that going through examples like the ones that were presented made it very clear to me about sort of lessons learned. The thing that I would take away, in addition to the publication issue that I commented on, is that intent is really the most important thing. If you're honest and thoughtful about your intent, and honest and thoughtful about your intent when you go to ask the IRB, the likelihood of success navigating this issue is very high, I think.
And Dr. Schreiner and Dr. Fiks, were there other reflections you had on Dr. Taylor's presentation or other issues you would like to stress to the group?
Holly, I wondered if you've had a chance to reflect on Alan Tate's work with electronic means of obtaining consent, which have branching pathways to allow people to get more or less information and utilize graphic elements to enhance understanding. Have you had a chance to look at or reflect on how that might fit in?
You know, maybe not to the level of detail that could speak deeply about this, but I think the general rule that I would say is true is that anything you do to facilitate understanding is a good thing, right? So providing someone with an electronic gadget that facilitates understanding and allows them to go deeply into a topic. So I'll use randomization as an example. Randomization is just chronically a topic that patients don't quite understand. I don't know how their particular intervention addresses the issue, but any creative way to help a subject really understand what randomization is going to benefit individuals. It's almost never the case, I think I can say, it's never the case that intervening reduces understanding, that although results that we have previous show that understanding is about the same whether or not you do something or you don't, I think we still have to give the do something arm of the larger experiment more time to really find out whether or not we can facilitate understanding. I also just think the more, because people take in information differently, right? Adults, we know that adults learn differently. Some of us learn best by listening, some by viewing, some by working out a problem ourselves. The more we can tailor options to individuals, to their preferences, I think the better off we're going to be. And I really think that the electronic modalities have a lot of promise in tailoring information. That said, I really think we need to systematically assess whether or not the understanding is improved, right? But I wouldn't want it to be the case that we think one size fits all and we all buy tablets for all of our patients and clinics. I'm not sure that I would say that's the best way to go just yet.
Thank you. I have a question for Dr. Schreiner and Fiks, and I can't identify which example, but the question was posed. Could you please clarify between the application of existing knowledge and translational research?
Okay. Well, translational research generally means going between concepts and promising new discoveries in the basic science realm, so animal, other laboratory research, and moving towards early phase studies in humans. So translational research is that translation from basic science to clinical application, whereas when we're talking about quality improvement, it's about application of interventions that are known to work. Putting soap dispensers next to the bed in each room, putting signs up to wash your hands. Those kinds of things happened about from iterative processes, and each month people looked at the infection rate and kept adding or changing those interventions until the infection rates went down. So the program at Hopkins, the research that showed that following a checklist and a bundle of interventions reduced central line infection, was then implemented in a number of hospitals in New York, but they were applying the program that had already been shown to be effective, and although initially they were cited for conducting research without IRB approval, ultimately that was reassessed and agreed that this was the application of existing knowledge and was not research. So,
and it was Michigan, by the way, not New York.
Michigan? Not Hopkins? I thought...
No, Hopkins did it, but the work was done...
in Michigan, not New York?
Michigan, New York, yeah.
Yeah. So that was a very controversial episode, and I think it helped ultimately to clarify what was what. But initially it seemed very chilling that if this was going to be the standard.
So some questions have come up with respect to de-identified data or secondary data usage. And have you ever known of a situation where you have de-identified data where there still may be concern with respect to needing IRB approval?
The only situation that I'm aware of is the sharing of data with the dbGaP database at the NIH. So investigators who have done GWAS studies, and we're going back a few years, could contribute their data to dbGaP, provided the IRB certified that it met certain conditions. Now, the data was going to be stripped of identifiers, so technically this is not an IRB question because the IRBs are only concerned with human subjects research. Nevertheless, we were asked to do that. So I think that even when the data is de-identified, the investigator has an obligation to respect the promises made in an informed consent form regarding potential for future use. And the consent form could be silent on that matter, or it could specify a limited range of research topics that could be the data or samples could be used for, or it could be a very broad range of topics for which the research could be, the samples and specimens could be reused. And it's the investigator's responsibility to respect the subject's wishes and to keep track of those wishes, but it is not the IRB's job.
So
point out also that institutions have human research protection programs. The IRB is only a part of that program, and that there are other individuals that may have some responsibilities by hospital policy for oversight for those activities.
Thank you very much. So some of the questions posed have to do with if you have multiple sites, different institutions conducting the same research, and the extent to which one or more IRBs may need to provide consent. And I'll just put a plug in. Last year we had a fabulous national webinar which is available on YouTube about hierarchical IRB approval and or concerted IRB approval across multiple organizations and sites. And so when we send the PDF file for this fantastic presentation, we'll include a link for that. And they talked about different strategies and the evolution of some organizations' willingness to yield their authority for overview of IRB for a project that may occur in their organization that yet may have a different organization as the lead organization. And those are the examples that were discussed. And with that said, I'll open that up to our current presenters if they care to comment on multiple IRB review.
Well, the NIH is increasingly requiring that clinical trials and other groups use a single IRB, or at least set up a structure to organize one. The PCORI grant for I think it's called PEDSNet, Pediatric Network, which involves 8 institutions, has organized a central IRB structure for those studies done either under the PCORI grant or any other study. So we now have those 8 signatories, and since then I think we have 2 or 3 more. So we now have 11 institutions that have agreed to cede review to the other institutions. I will give an example, though, of a database where the Data Coordinating Center offered to be the IRB of record for my institution, and they were requiring written informed consent for this quality improvement activity, because there was also the intent to eventually do research, we declined to participate because we determined that it was not human subject research, and therefore our investigators would have had additional regulatory burdens, which points out that different institutions display different levels of conservatism. And while I may think something as quality improvement does not require IRB review, does not mean that every IRB in this country will see things the same way. And that is, there are differences between institutions in how they treat these things. I think there's a lot of mission creep in the IRB world, and I think that that should be resisted, and we should try to have our IRBs stick within the regulatory boundaries and not go beyond what our obligations are. So we are widely open to cooperative agreements. We must have well over 100 in effect right now, 100 studies under cooperative agreements, and I think that they will help in some ways and they'll hinder in others.
Thank you. I'm just scrolling through. There are a host of what if for particular research studies, which I'm not going to read, but to see there isn't a discussion point that we could. Dr. Taylor, with respect to your fact sheet that you spoke about, to what extent did you check or did you intend for it to conform to the elements of informed consent from the Code of Federal Regulations, Part 50.25? Do you remember? Was that an issue for you all?
Well, you're welcome to look at the publication. I can say with close to certainty that all of the key elements are included in the fact sheet. Our goal was not to supplant the consent form. It was to complement the consent form. Our IRB would not let a fact sheet like this supplant the informed consent process. Our goal was to highlight, in collaboration with the study team, what the most important issues were for the subjects. 9 times out of 10, if not 99 out of 100, there was agreement that risks were important, benefits were important, key procedures were important, voluntariness is important, point of contact is important. So, as I say, it's not something we sort of said, it must adhere, but as I said before, I can't imagine that there's much difference between the two. Right? If you took the list from the CFR and went to one of our fact sheets, my guess is you could tick off each of the required elements as present.
Well, thank you.
The FDA has a draft guidance on informed consent in which they make the point that if the procedural details make the form too complicated and long, that the general issue can be discussed and that the details can be provided in other formats aside from the consent form. So the FDA is trying to move to simplify the consent form.
Yeah, I mean, which I certainly applaud. I think, the world catching up to such a thing is going to take quite a long time.
Yeah. So Holly, find a collaborator here at SHOP because we'll approve your consent form, your short version.
We'll talk.
Well, I want to. You guys gave a fantastic presentation, and the level of confidence that your participants had in. Because they, and the many other questions that I didn't read where they wanted your opinion to parse whether or not a particular study was human subjects or quality improvement is a reflection of that, and I'm sorry to the participants who took the time to compose, but I just don't feel comfortable with the use of us proceeding in that way, too quick of a fashion. But excellent questions have been posed, thoughtful deliberations have been provided, and with that, I will remind folks to continue on and watch the directions with respect to how to attain CME credit. And for those of you who, which is on the website now, we have a few more webinars that will be hosted by the PBRN Research Center. And in July, we have a dissemination, implementation, research, and health, translating science to practice. That is one of the 4 areas of interest in AHRQ's new in the last year of its foci. That should be very exciting. We also are going to be pursuing an adaptive trial design and learning evaluation national webinar. That too was recommended by the participants of the Pragmatic Trials Working Group. And then our Swan Song PBRN Resource Center webinar will be held on September 9th using rapid cycle research. It's an interesting framework begun by Dave Gustafson that has been modified based on input from PBRNs, and is a wonderful treasure trove of different types of methodologies to use, and really talks about the continuum of explanatory and predictive trials along the way, and some of the common methodologies that can be used. And so with that, I do ask you, if you don't mind, to complete the exit poll to evaluate the particular national webinar, and to let us know other areas of interest to you. And again, Dr. Fiks knows I absolutely love baseball, and if I could provide an image of in the Philly Stadium where everyone's standing up, giving our 3 presenters waves, I would. It was very well presented, very thoughtfully discussed, and certainly an enrichment to our repertoire at the PBRN Resource Center. So thank you all, and thank you, Christina, for organizing us. Hope everybody has a good day.
Bye.
Bye.